Assalamu alaikum. It's my pleasure to be part of the first Jordanian Heart Failure Summit. And I don't have extra time, Dr. Wright, so I will use all my time. I have to admit I'm not an expert in the field of iron deficiency and heart failure, but maybe we all can go back and discuss iron deficiency that we all learned in the internal medicine before. It's a new comorbidity in heart failure, and it's a new therapeutic target to improve our patient's symptoms and maybe prognosis. It's widely present if you look for it and frequently overlooked in our patients. It's estimated prevalence of much more than 30 to 50% of our patients with heart failure presenting, they do have underlying iron deficiency. Iron deficiency contributes to cardiac and peripheral muscle dysfunction because we know all iron is part of the hemoglobin, it's part of the myoglobin, it's part of many enzymes that we use in our muscles. And iron deficiency can lead to decreased exercise tolerance, especially with anemia. And it has been shown that when the transferrin saturation is less than 20%, it has been associated with low peak oxygen consumption. And there's a trial done on about 160 patients where the iron was replaced with IV iron, where we showed improvement in the peak oxygen consumption in these patients once you replace it. Prognosis, iron deficiency in heart failure is an independent predictor of worse functional capacity, and it's also an independent predictor of survival. And this is independent of hemoglobin. We all know that hemoglobin anemia in patients with heart failure is an independent prognostic factor. You have somebody with heart failure and you have anemia with that, they do worse than patients with heart failure without anemia. But iron deficiency by itself without anemia is also an independent predictor of worse morbidity and mortality in patients with heart failure. Because of this renewed interest in iron metabolism in these patients, there have been a new research and new investigation in the iron metabolism in the body. For example, there is an interest in this molecule called hepcidin, which is an acute phase reactant produced by the liver that inhibits iron transportation on the ferroportin on the gut mucosa cells as well as in the macrophages. And high level of hepcidin, which was found in patients with heart failure, prevents the iron absorption. And this is one of the reasons why oral iron therapy in patients with heart failure may not work. There is also interest in this molecule, the hepcidin, in other conditions, for example, in thalassemia, where they trying to increase hepcidin level in patients with thalassemia to prevent iron absorption, to prevent iron overload. So this is to say that this area of interest has been more and more research is going on in this field of iron metabolism. The definition of iron deficiency in heart failure is a little bit different from the iron deficiency that we are used to. To define iron deficiency in heart failure, you have to have a ferritin level of less than 100 microgram per liter, or if you have a ferritin level between 100 to 300 micrograms per liter, you have to have a transferrin saturation less than 20%. Definitely, if you have anemia, in addition to iron deficiency, you have to look for underlying cause for the anemia. Usually GI losses for underlying disease or reduced production, but that workup has to be done. This is slightly different from other chronic conditions that have iron deficiency. If you have a condition with inflammation, the ferritin level we go with is less than 100. But if you have no condition with no inflammation, we go with a ferritin level of less than 30. And this is a list of the other conditions. For example, in chronic kidney disease with dialysis, you go with a ferritin level of less than 200. If they have inflammatory bowel disease and they don't have any inflammation, no activity, you go with a ferritin level less than 30. Just this is to say that the ferritin itself is also an inflammatory marker. So this is why we choose a higher level of ferritin level in patients with heart failure because of an inflammatory condition that we have there. Risk factors for iron deficiency in heart failure. The usual risk factors that we have, female sex is usually more likely to have iron deficiency. Advanced heart failure with other things like higher level of N-terminal pro-B, BNPs, a higher level of C-reactive protein. These are increasing your risk of having iron deficiency. There's a lot of study and publications done in this recently in the last 20 years. This is a busy slide. The idea is all these trials were done in patients with symptomatic heart failure, with New York Heart Association between 2 and 4, and ejection fraction reduced between 35 to 50%. This is to keep in mind which patient we need to treat later on with iron deficiency. In these trials, they use the same definition we have for iron deficiency that we talked about just a minute ago. And in these trials, the hemoglobin level was anywhere between less than 15 and more than 8 to 9. So hemoglobin was not more than 15. It has to be less than 15 and more than 8 to 9 to be included in these trials about iron deficiency in heart failure. There are multiple studies done in this field. Just I want to point out, early on we had trials done. The Red Heart Failure study looked at the erythropoietin in heart failure patients, and those trials came back completely negative. We're going to comment on that at the end of this presentation. And these studies were done on different forms of iron supplementation we're going to talk about. I'm going to discuss today the CONFIRM trial. It's one of the trials done in Europe about iron deficiency. It's a multi-center study, double-blinded, included patients with symptomatic heart failure, ejection fraction less than 45%, with evidence of heart failure. In this study, they used ferric carboxymaltose, the iron formula to supplement the iron deficiency. And this is the protocol for people who are interested in knowing the protocol used in that study. In the initial phase, they used up to 2,000 milligrams of iron, IV iron, in 2 or more sessions. And then iron level was checked, and later on, and based on the calculations, they would either give patients more iron or not. And this is the longest study. People were followed up for 52 weeks. And in this study, as you see, this, like the patients we see in our offices, they were like both groups of patients were around 70 years old. Half of them were women, mostly white, and symptomatic, as we said, between 2 to 3, New York Heart Association, with ejection fraction on average about 36 to 37%. The primary endpoint in the study was 6-minute walk at 24 weeks, and there were significant improvement in primary endpoint by the ferric carboxymaltose IV therapy in these patients with a significant p-value, with improvement in walking distance around 33 meters or so. This was the primary endpoint in this trial. There were also improvement in patient global assessment questionnaire in these patients, starting at 12 weeks with a significant p-value. Similarly, there were improvement also in New York Heart Association class, starting around 12 weeks, and this maintenance was maintained the duration of the study of 52 weeks. To our surprise in this trial, time to first hospitalization due to heart failure was also improved with a significant p-value. Patient who received the IV iron, the ferric carboxymaltose, they had less worsening, admission for worsening heart failure than patient who received the placebo treatment. In this trial, the secondary endpoint, there were no significant improvement in mortality. Again, this was not designed to look at that. The number of patients were not enough to look for that. But again, it was not designed for it. No change in hospitalization. Again, there were only significant improvement in hospitalization due to worsening heart failure in patients who received the IV carboxymaltose. The conclusion from the CONFIRM heart failure trial: treatment of stable symptomatic iron-deficient heart failure patient with ferric carboxymaltose over a 1-year period resulted in sustained improvement in functional capacity, symptoms, and quality of life, and may reduce hospitalization due to worsening heart failure. Again, there were no improvement in mortality. This is a meta-analysis looked at patients who received supplementation with iron in heart failure patients, included 10 trials. 8 of them were IV iron, including 1,400 patients. And this was published recently in 2019. It showed that iron supplementation improved hospitalization, improved New York Heart Association class, improved 6-minute walk test, improvement in LVEF with a WMD, weighted mean deviation, 3.81, improvement in serum markers of heart failure and inflammation, and there were no improvement in mortality. This is another meta-analysis published last year, looking only at the studies which use ferric carboxymaltose, and they combined hospitalization and mortality in these patients, and there were significant improvement in combination events in patients with heart failure. So how do we treat patients with iron deficiency and heart failure? Most controlled studies used IV iron, either IV ferric carboxymaltose or IV iron saccharose. The preference seems to be more towards the ferric carboxymaltose, as we showed in the trials above. And because you can give a higher dose of iron and you can correct the deficiency of iron deficiency in these patients in a quicker manner using the ferric carboxymaltose than the iron saccharose. This has led to the differences in societies. The European Society recommends only ferric carboxymaltose as a replacement therapy, while in the US, they say IV iron. They do not recommend certain compound for that. As far as oral iron heart failure, to date there was no data and no trial has shown the efficacy of oral iron in iron deficiency in heart failure. The problem with oral iron preparation is high incidence of adverse effects, up to 40%, poorly absorbed because of wall edema, as well as high pepsidine level that we talked about before. And it can take up to 6 months to replenish iron stores. There were a recent study in 2016 called the Iron Out Heart Failure. In this study, they had 225 patients with oral iron polysaccharide versus placebo. And the primary endpoint was the peak VO2 uptake. And it was a negative study with negative p-values and that. When they looked at other secondary endpoints, they were all negative, including 6-minute walk, including markers, Kansas questionnaire, all that stuff. All the secondary endpoints were negative as far as oral iron polysaccharide in iron deficiency and heart failure. Even in the study here, when they looked at the iron levels after oral iron treatment, there were no improvement in ferritin level or transferritin saturation, while if you look at study like the FAIR heart failure, which are IV iron, ferric carboxymaltose, there were improvement in the ferritin level with IV iron. There were improvement in the transferrin saturation with IV iron. So guidelines. The heart failure guidelines, both across the Atlantic, recommend that all patients with a newly diagnosed heart failure should be tested for anemia and iron deficiency. The recommendation from the guidelines is to use serum ferritin and transferrin saturation as far as iron deficiency in heart failure. Now, in some patients, you may need to do more internal medicine work in these patients, looking for total iron, iron binding capacity, maybe some transferrin molecule receptors, and maybe bone marrow. But for the most patients, serum ferritin and transferrin saturation is good enough to make the diagnosis for iron deficiency in heart failure. The European Society of Heart Failure recommend intravenous ferric carboxymaltose in patients with symptomatic heart failure with reduced ejection fraction and iron deficiency. The same definition we use, less than 100 mics per liter, or ferritin between 100 and 300 to use a transferrin of less than 20% in order to alleviate heart failure symptoms, improve exercise capacity and quality of life. This was done in 2016. Subsequent studies did not change that recommendation. It's a class 2A recommendation. There are some ongoing studies right now with a larger number of patients to look at this topic and see if we can improve prognosis even better in these patients. In the ACC 2017 updated heart failure guidelines, it's a 2B class to use in patients with New York Heart Association class 2 and 3, iron deficiency, the same diagnosis. To use IV iron, intravenous iron replacement may be reasonable to improve functional status and quality of life. It's a class 2B recommendation. Again, in patients with heart failure and anemia, erythropoietin-stimulating agents should not be used to improve morbidity and mortality in patients with heart failure, because it has, in a study called the red heart failure, it has been shown that it increases thromboembolic disease and increase mortality that way. To summarize things, you get somebody with symptomatic heart failure with reduced ejection fraction, New York Heart Association class 2 to 3, and you check hemoglobin. If the hemoglobin is less than 15, you go down this way. If the hemoglobin is more than 15, there is no role for IV iron. If the hemoglobin is less than 15, you check the ferritin level and transferrin levels, and if it is less than, if they are iron deficient, you consider giving them IV iron treatment, and recheck them in 3 to 6 months and see if their iron levels has improved or not. Again, this is an evolving subject to improve patients with heart failure symptoms and improve their exercise tolerance. And I believe it's widely present and overlooked, and we don't check patients for that. This is a good resources to review articles looking at the same topic, came out recently to look at this topic. Any questions?
Yeah, we have a few minutes for questions.
It's not a question, it's a comment. Transferrin is not a test that you order, it's a calculation. So what you have to do is you order the serum iron and you order the total iron binding capacity. And then you divide the serum iron by the total iron binding capacity and you get the transferrin level. So it's not a test that you order separately. It's what you do. So you have to order iron and total iron binding capacity, and then you can do the calculation and get the transferrin level. I just wanted to point that out.
Thank you, Ramzi. Many labs, they do the calculations for you. So many labs, when you order that, they give you the number back. Thank you, Ramzi.
Dr. Omar, thank you.
Thank you.
I wonder about the mechanism of iron in heart failure. Sometimes you encounter, even not in heart failure, in other cases of hypertension, iron deficiency without the obvious causes of iron loss or blood loss.
I'm not sure exactly what to say, but as I said before, iron is an essential particle of the myoglobin. It's an essential particle of the hemoglobin. And it has been shown when it's reduced, you have dysfunction. You have dysfunction of the oxygen transportation, oxygen extraction in tissues, and also you have dysfunction in the muscles itself. And as I said, there are studies have shown that when you give people IV iron replacement and you improve their transferritin level and resveratrol level, and then you do for them the oxygen, actually I have a slide on that, and when you give them the, when you check their peak oxygen uptake, you see improvement in their peak oxygen uptake based on that. As far as iron deficiency in other conditions, I'm not aware of that. I'm not sure there's anything in heart HFpEF for the iron deficiency. I'm not aware of that.
We have a question here.
Thank you. Most of our patients, we are afraid from anaphylaxis to give iron injection IV. Can we give in our clinic? And all the studies on HFpEF or HFrEF, that's positive, or both? Thank you.
As far as iron therapy, the IV iron is better to be given in a supervised setting, usually in either the ER or some a setting where you are can react in case you have a reaction. And all the studies were done with the new formulas with IV iron. The side effects are very, very, very few. But again, we cannot give IV iron in our clinics unless we are set up for that. As far as the HFpEF question, as Dr. Iyas said, all studies done on HFpEF were negative. There were no positive study in patients with HFpEF.
Omar, very interesting talk and actually very interesting topic these days. But really what we see in Jordan, I don't know if you have answer for this question, which I see very frequent in the clinic. A patient who has heart failure and is still smoking. And the hemoglobin is very high and the iron is very low. What do you do in this situation? Do you send patients for blood extraction and you give iron? Or
I
there is no
don't-
study I know about this, but
I don't have an answer for that, but the guidelines specifically say if your hemoglobin is more than 15, you do not give people iron. This is in the guidelines because there's a risk of iron overload. Now, if your hemoglobin is more than 15 and you're iron deficient, I don't know. I don't have an answer. Anybody?
I think we can do a study on this in
study
Jordan.
on
I think
this, or you
very,
just-
very suitable environment actually
The
for such a study.
easier way is to tell them to quit smoking.
That's fair.